After having learned what to see on the mammogram, we continue with a technique how to view a mammogram. This is the worst way of viewing a mammogram. There are colleagues who are putting up the current MLO, yesterday's MLO, the previous exam, previous, the current CC and the previous and previous and previous. Dear colleagues, this is information overload. I guarantee you, this is the best way of missing a cancer. I'm going to shock you. I'm not going to recommend for you to do either this. No, just two on the screen. This is medical history again. Our study, the WE trial, is really the foundation of screening all over the world. I'm thinking more and more about the secret. Why did it succeed? Well, many components, of course, but I think this little black box. You lift up the black box. Now this is yellow because my colleagues thought this was so valuable, so they sprayed gold into it and they put a nice little label. Thank you, Laszlo. Anyway, these are magnifying glasses. And these are, depending on your eyes, 2 by or 3 by or 4 by magnification. Basically, it does this. It excludes the ambient light. It enlarges the image. Dear colleagues, this is to view a mammogram. You have one pair of images, and then side by side, step by step, you are viewing the mammogram and constantly magnify the image. But then the full-field digital mammography arrived, and suddenly this wonderful knowledge disappeared. We don't know anymore how to build pyramids, right? And young radiologists don't even know how to spell the word darkroom. They don't know how to develop films and so on. So, dear colleagues, don't look at a mammogram this way. You should always use that beautiful big field on your screen. Imagine that your head is in the black box. You only see the right and the left axilla. Give 2-3 seconds for your eyes and for your brain. Look at the contour. I could have asked you whether you saw something on a mammogram. No, you would have missed. Look at these calcifications. You don't see the calcifications without enlargement. Using the enlargement, the side by side, step by step, you find the lesion, which you would have missed otherwise. So now you got the message. Let's practice. Asymptomatic, 56-year-old. I'd like you to pull out your telephone because now we are going to interact. She has this kind of mammogram. This is how colleagues look at mammograms. I'm giving you a large enough number of seconds. I don't think you stayed too many seconds on looking at a mammogram. Would you mind voting? Would you call her back? Yes or no? What we read out of this polling is that 86% want to call back, 13% not. If the polling result is 38% left breast, 50% right breast, and 13% no finding, that tells me a lot of insecurity. So then we have another question. Of those colleagues who wanted to call her back, my question is, asymmetric density or calcifications? The colleagues say 88% wanted to call back, about 40% for the left breast, and 75% for asymmetric density. Thank you very much. You are absolutely great. Now comes my teaching. I'm going to ask you the question, why would you not use this beautiful big field here? Gave a lot of money for buying that monitor. This is it. This is my teaching, right? I'm driving the enlargement all the way so that skin touches the edge here. Side by side, I'm going to ask the same questions you just answered. Most of you wanted to call her back for the left breast for asymmetric density. Question number 1. Would you call the patient back? Yes or no? Here's the magical, the 80% became 100%, and the left breast became right breast, and the 80% asymmetric density turned to calcifications. Dear colleagues, did you get the message? You obviously did. Let me go back to the PowerPoint. This is shocking because if you don't do this, then you are going to miss the lesion. In that case, you need help. The artificial intelligence already pointed it out. Artificial intelligence didn't bother about the normal parenchyma on the left side, or you have to use the masking technique. And then you call her back. This is what you do, and you say, this isn't a TDLU, and they are crushed stone, discernible calcifications. But there are 3 benign and 1 malignant option. In decreasing frequency, fibrocystic change can look like this, fibroadenoma can look like this, papilloma can look like this, and of course, grade 2 cancer in situ, not DCIS, because this is an acinus. I have 3 for the benign and 1 for the malignant option. Who is going to be the arbitrator? The stereo device, and congratulations for a colleague who hit it. This is not fibrocystic change. This is not fibroadenoma, not papilloma. This is carcinoma. But mind you, if your pathologist calls this a duct, he or she is wrong. This is an acinus. This is a terminal duct, and these are acini. And so comes the shock. Are you using breast MR on every single core biopsy proven cancer? Please do that, because suddenly the disease is not localized to a tiny little spot, but from the chest wall to the nipple, it's 8 centimeters. You fell in love with this one, and you just missed an 8 centimeter carcinoma. But if you listen to me, you are not going to miss it. And that's exactly what you proved to me. I ask you, enlarge it, and then suddenly 100% found a cancer. Look at this discrepancy. Here it is, this tiny little TDLU, but this is non-mass enhancement. What makes non-mass enhancement? Cancer in the ducts. If you are a smart radiologist, you don't do this because you already saw this one. So you talk with the surgeon, this is a mastectomy case. Don't do that. All this has to go. That's what the MR showed. Unfortunately, the radiologist told the surgeon by localizing a little tissue that this should be taken out. He made a mistake. I don't know whether you always magnify the surgical specimen. Please do that. One very important advice. Magnify it. That's not good enough. Pathologists should slice by 5 millimeters the specimen. In our place, the fresh specimen comes back and the slices are magnified. Whoops, what a difference. I thought it was only 1. But the MR told there is much more here. It's cancer here, it's cancer there, it's cancer everywhere, and the MR suggests that there is carcinoma here too. Is that true? Well, it is. The teaching point to take home when you see multiple cluster, malignant type, histologically proven, crushed stone pleomorphic calcifications, the cancer was not born here. The cancer was born in the major ducts, and they went down to the TDLU, where they calcify very early. It's called cancerization of the lobule. Here it is. I'm going to show you more. So what we found originally was this. But look at this. And these are very contorted. They don't have TDLU. This is a terminal duct. These are the acini. But what is this? These are newly formed ducts. Here is the side arm. We call it duct-forming invasive carcinoma. Unfortunately, pathologists call it DCIS, but they cannot explain to me why these patients run a 30% risk of dying from the disease. Do you really believe that milk was running in this duct system one day? No, this is newly formed duct, neoduct genesis. And I'm not impressed when the colleagues are using the anti-actin staining to prove that there is myoepithelial cell layer. No, it's not. It's not myoepithelial cell layer. It's positive for actin. The farmer's common sense says that this is abnormal. Just look at the shape. I don't care about the staining method. This is invasive carcinoma. Yes, indeed. And it's not even very nice here and there. Here it is grade 1, but here it is grade 3. So, dear colleagues, that was one very educational case. The interaction continues. So far, you learned something that at least 3 or 4 out of the 4 basic building blocks I need to see in order to say normal mammogram. And it's a very easy case when it's symmetrical. Density here, density here. I can sign this case. Mrs. X, you do not have a mammographically demonstrable malignancy, pathology, and I can, with good conscience, explain every single modular and linear density. In mammography, although the radiologists are afraid of calcifications, I don't think this is the biggest problem. The biggest problem is what we call asymmetric density on the mammogram, and every second woman has it. And the definition is that on the corresponding area of the other breast, there is no such density. So how am I going to analyze this? Very simple. I'm going to ask myself a question. Do you see TDLUs? If the answer is yes, I already have one basic building block. And if I can distinguish one from another, then it's fat. Okay, I already have 2. And if there is concave contoured fibrosis, homogeneous ground glass-like, that's enough for me to say 3 out of 4 basic building blocks. Mrs. X, you do not have mammographic abnormality. This is just a specific asymmetric density. It's unequivocal. I put my name on it, and you got a well letter. So now, I would like to invite you to a quiz again. Here is her mammogram, MLO, and CC projections. MLO and CC. Would you call this patient back? I show it again. Call back, yes or no? 100% would call back, and 100% left breast, and 100% asymmetric density. Wonderful. Unanimously, everybody want to call the patient back for asymmetric density. Now we are going to do what we just learned. Enlarge. You have to look behind the nipple, the lower half of the breast. I guess this was bothering you a little bit. But when I'm enlarging this one, this is what I would recommend for you. Try to answer the question. Ask the question and you yourself answer. Do you see terminal ductal lobular units? 1, 2, 3, 4, 5, 35. Do you see some linear densities? Do you see fat? Can you conclude that these are 3 basic building blocks? Or, and now comes a very important teaching point, say, Laszlo is showing me a 3 by 3 centimeter stellate lesion with a central tumor mass, straight speculations. Laszlo is showing me a circular lesion, homogeneous, ground glass-like, microlobulated. Which one would you choose? The colleagues, and myself included, concluded that this is just normal fibroglandular tissue. And this is a remnant of normal fibroglandular tissue, and this one is too. If we look at the right breast, it's exactly the same. This is the little, and this is the big in the same family. Try to convince yourself that this is a circular lesion. No, stellate lesion. No. We gave her a well letter with good conscience, and then 3.5 years later, she comes back. So then, would you mind telling me now when I enlarge and do the trick and show the previous mammogram, show this, would you call this patient back? And if yes, why? After all this explanation, please tell me Why would you call her back when there is no stellate lesion, there is no circular lesion, there is no calcification, and there is no reason? You can explain that this is nearly entirely gone and this is on the way to disappear because 3.5 years later looked like this and now it looks like this. Dear colleagues, next case, first screening, you have no access to previous mammogram. I'm going to ask you to vote twice. Without enlargement, would you call this patient back or not? 100% yes. Asymmetric density, wonderful. Now I'm doing the same thing. I'm positive this is something the colleagues are worried about, not in the axilla, not in the right, it was the left, and there is nothing else in the left. So analyze this, and I give you a few seconds, and now the same density, follow the thought. Do you see many enough basic building blocks, or convince yourself that this is a 2 by 3 centimeter stellate, circular lesion? Here is the same case 2 years later on the MLO and on the CC projection. Dear colleagues, I'm showing normal asymmetric densities. And here I could convince you that it's full of TDLUs, fat and concave contoured fibrosis. I don't see ducts, but I see 3 out of 4 basic building blocks. Now I'm cool because I didn't call her back at this time point. I didn't call her back at this time point, but I give you an additional 2 years. When it starts to shy away, winter time is coming, it's going to disappear. You see that? More and more fatty replacement, and there is no cancer here. These 3 cases, I hope, are going to be enough to drill in the teaching points, how to handle asymmetric densities. Let's go to pathology. After we learned what to see on the mammogram when it's normal, how to view a mammogram, let's focus on cancer. Teach me how to find the breast cancer early. I want to be a good doctor. You actually ask a question which is more complex than you think. You're asking 2 questions. What does it look like? And is there any spot on the mammogram where most of the cancers are localized? So I'm going to always look there. So let's take the first one. What does a cancer look like? And that's, dear colleagues, we call the 3rd generation biomarkers. Most of the cancers originate from the terminal ductal lobular units, and as long as they are in situ, they are either multiple cluster, not countable, cotton ball-like, powdery calcifications, and the pathologist says grade 1 cancer in situ, or crushed stone-like calcifications discernible, and then the pathologist is going to say this is a result of necrosis, grade 2 cancer in situ. Just don't allow them to use the word duct because it's not a duct. And then the basement membrane gets dissolved and the cancer starts to infiltrate. So you have the stellate lesion or the circular lesion. Dear colleagues, whenever you see a stellate and circular lesion, you should know that it originates from the acini, and for that reason we call it acinar adenocarcinoma of the breast. Just like the colleagues, the pathologists, use the term of describing a prostate cancer, they call it acinar adenocarcinoma of the prostate. Or in the salivary gland, they call it acinar adenocarcinoma of the, let's say, parotid. Unfortunately, in the breast, they mess up with terminology, so we try to convince them, call it acinar adenocarcinoma of the breast, just like you do it in the other fluid-producing organs. What is the imaging biomarker of the most frequently occurring cancers? These 4. What is the imaging biomarker of the cancers originating from the major lactiferous ducts, accounting for 20% of all cancers? There are 6. 4 of them are calcified. The 5th one is architectural distortion, and then the galactography, bloody nipple discharge. We'll talk about it. And the cancer, what pathologists conventionally call diffusely infiltrating lobular carcinoma, look here. It's like uncombed hair. like spider's web, the only imaging biomarker of 5% of all cancers. This is the reason why we published in European Journal of Radiology our articles. We really have to take the site of origin of cancer into account, because where it originates from determines the long-term outcome. Acinar adenocarcinoma of the breast, stellate lesions, you and I can control. Cancers originating from the major ducts, DABs, neither you nor I can control. And this devil, the architectural distortion, totally uncontrollable, both for screening and for modern therapeutic regimens. So this is what I wanted to express here very quickly. Those that originate from the TDLU, their histology, 3D, and their mammogram. Those that originate from the major lactiferous ducts, long branching calcifications, and architectural distortion. Please keep in mind that these two are unfortunate because they are stem cell carcinomas, and we could not improve their long-term outcome. This is an outlier. If a cancer is huge, 10 centimeter, and concave, while even the smallest acinar adenocarcinoma is convex, and this never calcifies, the AABs and the DABs 30% calcify because they originate from the glandular tissue. We believe that this originates from the mesenchymal stem cells. That's why we call it breast cancer of mesenchymal origin. Please read the articles. You know, in life, the most important thing is the outcome. I classified 1,000 cases in Virginia, back in Sweden, another 1,000, 2,700 in Turin. Dear colleagues, these curves have 4,700 women's 20-year outcome. This is the success story of screening. You and I can replace the huge apple-sized AAB with the small one. But the same physician, the same technologist could not improve the DABs, and this is the future task for research. The cells within the acini one day produce the milk. Now they become cancer cells, and this is what's going to happen. We don't know why. What pulls the trigger? You don't even see the acini, but now you suddenly see them. Because the cancer cells accumulate. The orange color is going to be the necrosis. The black is the calcification, and here is real histology. But you and I put an X-ray tube above this. What do you expect? Well, of course, this is what you get. And then, look at the animation. The ever-increasing pressure. You see the calcifications here? These calcifications. And the pathologists call it DCIS. Please, kindly ask them, don't. This is cancer in situ, and this is the curable kind of cancer in situ. Now, this is lobular cancer in situ, where the finger structure is still there. So now we understand the pathophysiology as well behind the AAB. Not DCIS and not invasive ductal. Isn't that wonderful? As I promised at the beginning, good radiologists bring the curves up from here to there. That's why we save life. This woman has a 24-year survival probability as her neighbor who never got a breast cancer. Fortunately, 40% of them are unifocal. Unfortunately, 30% of them are multifocal. And multifocality is a poor prognostic factor. And this is when the large section histology again comes very handy. Dear colleagues, it's going to be your and my responsibility to send these patients for MR, because otherwise you don't know the real distribution. You see stellate, multifocal, this, significantly worse outcome compared to unifocal. Circular multifocal, bad news compared to unifocal.